It is not sadness. That is the first thing to understand, and the thing that most people around you, and possibly the clinician who has tried to help you, may have gotten wrong. The depression that most commonly arrives after 60 does not present as sadness. It does not produce tears or identifiable grief or a feeling that can be named and pointed at. It presents as absence. The grandchild arrives. You expected joy, something you once knew about yourself, the warmth that would move through you at a child's laugh, at a face that looks like yours did 40 years ago, is not there, not replaced by something negative, simply not there. The garden that once called you outside in the morning no longer calls. The book that you would have read in an evening now sits for weeks without being opened. You are present. You participate. You function. But something that used to be inside the function is gone. If someone has told you this is depression, you may have struggled to accept the word, because depression, as the culture describes it, looks like sadness. And you are not sad. You are flat. You are absent from yourself in a way that is quieter and stranger than sadness, and harder to explain to the people who care about you. What I want to tell you is that this specific quality, the flatness, the absence, the disappearance of what used to be there rather than the arrival of something dark, has a biological signature. And that signature points, in a growing body of research, not to a failure of the mind to manage its emotions, and not to a deficit that can be fully addressed by targeting the brain directly, but to a condition in the gut that is altering the 3 biological systems the brain's mood regulation depends on. At around the 9-minute mark, I am going to show you what a major clinical analysis of antidepressant response has found about the specific type of depression I am describing, the type characterized by flatness, fatigue, withdrawal, and elevated inflammatory markers. The finding changes what a responsible clinical conversation about treatment-resistant depression looks like. If you have tried 1 or 2 antidepressants and not achieved full response, what I show you at that mark is not a reason for despair. It is a reason for a different conversation. Stay with me for it. I have spent more than 3 decades in geriatric medicine. The presentation I have described, the absence rather than the presence, the loss of what used to be there rather than the arrival of something painful, is what I now recognize as the hallmark of a specific subtype of depression that the research is increasingly calling inflammatory depression. And it is the subtype that is most common in adults over 60, most frequently undertreated by conventional antidepressant approaches, and most directly connected to a gut condition that has been accumulating quietly throughout the years leading to the current moment. Let me give you the mechanism. And let me give you a way of thinking about it that I hope will offer something depression discussions rarely provide. Not just an explanation, but a direction. The brain's capacity for mood regulation is like a garden. Not a passive space. An active biological system that requires specific conditions to grow and maintain itself. It requires nutrients in the soil to produce the compounds that carry positive emotional signaling. It requires fertilizer to maintain the plasticity, the adaptability, the capacity to grow new connections and recover from difficulty. And it requires a clean water supply, an absence of the contaminating signals that, when present continuously, instruct every cell in the garden to shut down and conserve resources as if something is seriously wrong. Depression is not a garden that has decided not to grow. It is a garden under simultaneous drought and contamination. The nutrients are being diverted before they reach the plants. The fertilizer has run out. The water supply carries a signal that overrides the growth program. And in adults over 60 with the specific presentation I have described, the flatness, the withdrawal, the loss of what used to be there, the source of the drought and the contamination is the gut. 3 biological mechanisms, all originating in the same disrupted gut environment, all producing, at the brain end of the pathway, the specific experience of depression that the clinical language has not yet fully captured. Here is what those 3 mechanisms are. The first is the hijacking of the tryptophan pathway. Serotonin is synthesized in the brain from an amino acid called tryptophan, which the body cannot make and must obtain from food. When tryptophan enters the bloodstream from the diet, it follows one of 2 pathways. It can be converted into serotonin through the normal pathway, or it can be diverted into a separate biochemical route called the kynurenine pathway, Which pathway tryptophan takes is determined substantially by the inflammatory state of the gut. When gut inflammation is present, when gut dysbiosis and increased permeability are generating the lipopolysaccharide signal and the cytokine cascade I described in our discussion of anxiety, an enzyme called IDO, indoleamine 2,3-dioxygenase, is activated. IDO acts like a gate operator diverting tryptophan away from the serotonin pathway and into the kynurenine pathway instead. The nutrients in the soil intended for the plants that sustain the garden are rerouted before they reach the roots. What the kynurenine pathway produces from this diverted tryptophan is not neutral. One of its primary metabolites is quinolinic acid, a compound that is directly neurotoxic. Quinolinic acid damages neurons in the hippocampus, the brain region most central to emotional memory, mood regulation, and the capacity for positive experience. It impairs the neuroplasticity that the hippocampus depends on for recovery and adaptation. And it does so more aggressively in an already inflamed brain, in which the blood-brain barrier is more permeable and the microglia that would normally limit the damage are already in a state of chronic activation. This is the first mechanism by which healing the gut addresses depression at its source rather than at its symptom. Reduce gut inflammation, reduce IDO activation, restore tryptophan to the serotonin pathway, reduce quinolinic acid production. The soil nutrients return to the plants they were supposed to reach. And this is also the first part of the explanation for why an SSRI, which works by preventing the reabsorption of serotonin once it has been released in the brain, produces only partial response in inflammatory depression. If the tryptophan that should be supplying the brain's serotonin synthesis is being continuously diverted into quinolinic acid, the amount of serotonin available for the SSRI to preserve and recycle is significantly reduced. The medication is working on the recycling of a supply that is not arriving in sufficient quantity. The seeds are good, the soil is preventing them from germinating. Before I show you the second mechanism, and before I get to the 9-minute marker, I want you to hold on to one specific thought. Everything I am describing about the tryptophan pathway applies to the brain's serotonin, but the gut also produces its own serotonin in far greater quantities, as I have described before. Gut serotonin and brain serotonin are separate pools. Gut serotonin does not cross into the brain, but the gut serotonin system, when it is running normally, generates vagal signals that support the brain's own serotonin environment. The relationship is indirect, bidirectional, and enormously consequential. When the gut is producing its serotonin signals appropriately, it is helping the brain's own system work. The two systems do not compete. They collaborate, and both are disrupted by the same gut inflammation. The second mechanism is BDNF depletion. BDNF, brain-derived neurotrophic factor, is sometimes called the brain's fertilizer. It is a protein that supports the survival, growth, and maintenance of neurons, and that is the primary biological substrate of neuroplasticity, the brain's ability to form new connections, adapt to experience, and recover from difficulty. BDNF is what allows the brain to change. And depression, at the neurobiological level, is substantially a disease of reduced BDNF, a brain that cannot change as readily as it needs to, that cannot adapt out of the patterns the depressive state has established, that cannot form the new connections that would support a different emotional experience. The hippocampus, the brain region that shrinks visibly on imaging in chronic depression, is the area most dependent on BDNF for its structural integrity. When BDNF is depleted, hippocampal neurons retract and eventually die. The garden loses the structural elements that hold the soil in place. The landscape changes in ways that compound the difficulty of recovery. The gut microbiome is one of the primary regulators of BDNF availability in the brain. Through two specific mechanisms, the short-chain fatty acids produced when gut bacteria ferment dietary fiber cross into systemic circulation and upregulate BDNF gene expression in hippocampal tissue. And vagal stimulation, generated by a healthy, well-populated gut microbiome, directly increases BDNF production in the hippocampus through cholinergic signaling. When gut dysbiosis reduces fiber fermentation, because the bacteria that ferment fiber are depleted, or because dietary fiber intake has reduced as cooking motivation declines with the depression itself, short-chain fatty acid production falls. BDNF expression follows. When the dysbiotic gut reduces vagal stimulation, the cholinergic BDNF stimulus falls. The fertilizer runs out. The garden loses its capacity to grow. This is the neuroplasticity mechanism at the heart of why gut-driven depression in older adults often feels permanent. Why the hopelessness is not simply a cognitive distortion, but a neurological reality. The brain does not have the BDNF levels required to sustain the plasticity that recovery needs. It cannot grow its way out of the depressive pattern. Not because recovery is impossible, but because the biological substrate of recovery has been depleted. This is also why outdoor exercise, particularly walking, is the most consistently effective non-pharmaceutical intervention for depression in older adults. Not because it improves mood through positive thinking or distraction, because it is the single most potent natural BDNF stimulator available. A 20-minute walk outdoors increases hippocampal BDNF in ways that are measurable within hours of a single session. The fertilizer is restored through movement in a way that no other readily available intervention matches. And combined with gut restoration that is simultaneously increasing short-chain fatty acid and vagal BDNF stimulation, the two interventions address the same deficit from two different directions simultaneously. Now, the third mechanism, and then the 9-minute finding. The third mechanism is what the research is calling inflammatory sickness behavior becoming chronic. When the immune system encounters a genuine infection, it produces cytokines, IL-6, IL-1 beta, TNF-alpha, that alter the brain's behavior in a specific way. Fatigue arrives, motivation drops, social withdrawal feels natural, concentration narrows, appetite changes. The brain conserves resources and directs them toward the immune response. This is sickness behavior, a biologically useful short-term adaptive state. In a body with chronic gut inflammation, with gut dysbiosis generating continuous LPS from a permeable gut wall, with the systemic cytokine signal never returning to baseline the brain maintains this sickness behavior state indefinitely. Not because there is a genuine infection to fight, because the immune signal from the gut is indistinguishable at the brain level from a signal that says the body is continuously managing something serious. The fatigue that does not lift with sleep, the loss of interest in things that once mattered, the social withdrawal that is not chosen but that feels appropriate in a way that cannot be explained, the inability to imagine feeling different. These are the symptoms of sickness behavior, the brain's appropriate response to an immune signal that should be temporary but has become chronic. In adults over 60, this mechanism operates against a background of higher baseline inflammation than at 40, the inflammaging process that the research on aging consistently identifies. The cytokine baseline is already elevated. The gut permeability is already increased. The sickness behavior threshold is already lower. The depression that emerges is not manufactured by the mind. It is the brain faithfully responding to a biological signal that the gut has been sending continuously for months or years now. What I told you at the beginning to stay for. A major clinical analysis known as the STAR-D study, the sequenced treatment alternatives to relieve depression, one of the largest antidepressant effectiveness studies ever conducted, found that approximately 40 to 50% of patients did not achieve remission with their first antidepressant, and many did not achieve full remission across multiple medication trials. Subsequent research has investigated why. A pivotal series of studies led by researchers including Charles Raison and Andrew Miller found that patients with elevated inflammatory markers, specifically with hs-CRP levels above 3 mg per liter, showed significantly poorer response to SSRIs than patients with lower inflammatory markers, the same antidepressants, the same doses, different inflammatory profiles, different outcomes. But here is the clinical turning point in that research. The high inflammation patients who did not respond to SSRIs showed significant antidepressant response to an anti-inflammatory intervention, not to a new antidepressant mechanism, to a reduction in the inflammatory signal that was maintaining the IDO activation, the BDNF suppression, and the sickness behavior state simultaneously. The garden did not need different seeds, it needed the contamination removed from the water supply. When the inflammatory signal was reduced, the tryptophan pathway was freed, BDNF began to recover, and the sickness behavior state began to lift. For adults over 60 who have tried one antidepressant without full response, or two or more, the clinical language that often follows is treatment-resistant depression. The medications are considered to have failed. What this research suggests is that in a significant proportion of these cases, the medications did not fail. They were applied to a subtype of depression for which their primary mechanism, serotonin recycling, is insufficient because the upstream condition generating the depression is inflammatory rather than primarily neurochemical. And the source of that inflammation in most cases is the gut. A patient of mine, a retired engineer, mid-70s, whose wife brought him to the appointment because he had stopped doing the things that defined him, presented with what his family experienced as a man disappearing from himself. Not grief, not identifiable sadness, a progressive withdrawal from everything he had previously been. His garden, which he had maintained with pride for 30 years, had not been touched in 4 months. He participated in meals but did not initiate conversation. He said he was fine. He meant it. There was nothing acutely wrong. There was nothing at all. He had been prescribed 2 antidepressants over 3 years. The first had produced some activation. He had more energy for a time, but no meaningful mood improvement. The second had produced a similarly partial response. He was being considered for psychiatric referral. His hs-CRP was 4.8. Nobody had mentioned this in the context of his depression. He had been on a proton pump inhibitor for 7 years. He had had 4 courses of antibiotics in 3 years for chest infections. His diet had narrowed significantly as motivation to cook had declined with the depression. He ate largely packaged convenience food now, a narrowing his wife had noticed, but attributed to his mental state rather than identifying as a potential contributor to it. His gut had never been assessed. A comprehensive assessment revealed severe dysbiosis, elevated gut permeability, a tryptophan to kynurenine ratio significantly shifted toward kynurenine, confirming that IDO activation was diverting his tryptophan away from serotonin synthesis and BDNF levels at the lower boundary of the reference range. When the PPI was reviewed and a dietary approach to reflux management was trialed with his GP's close involvement, and when a structured gut restoration protocol was introduced alongside regular outdoor walking, 30 minutes each morning, rain or otherwise, the first change his wife noticed was small. 4 weeks in, he had gone back to the garden. Not with enthusiasm, just gone back. He had not mentioned it. She had found him there. By week 8, he was speaking at dinner without being spoken to first. By the 5-month review, his hs-CRP had fallen to 1.6. His tryptophan to kynurenine ratio had normalized. His BDNF had risen measurably into the mid-normal range. The antidepressant had not been changed. The dose had not been altered. The soil had been restored. The garden had not been forced to grow. It had simply found the conditions in which growth was possible again. His wife said it was as if he had returned from somewhere. Same man, same medication, restored the soil. The garden grew. Here is what I want you to take from this video into your next appointment and into this coming week. 3 specific steps, each one moving closer to the source. The first, ask your GP at your next appointment to run this specific panel and use these exact words. I have been reading about inflammatory depression and its distinct poor response to SSRIs in patients with elevated inflammatory markers. Given my hs-CRP and my response to current medication, could we measure my hs-CRP IL-6, and if available my tryptophan to kynurenine ratio, as a way of characterizing whether my depression has an inflammatory profile before we consider further medication changes? This question does something clinically important. It asks for characterization before escalation. It requests the information that determines which intervention is most appropriate for the specific type of depression present, rather than proceeding to a next medication in a sequence without knowing whether medication is the right primary target. The second, begin outdoor walking this week. Not for mood improvement through exercise. That benefit exists but is secondary. For BDNF. 20 to 30 minutes outdoors, as close to daily as your physical health allows. On days when the full time is not possible, 10 minutes is better than none. The BDNF response to outdoor movement in older adults with depression is documented and meaningful. It is the most direct intervention available for the neuroplasticity deficit at the heart of why inflammatory depression feels permanent. Combine it with gut restoration and the two BDNF pathways. Movement from outside and short-chain fatty acids from within work simultaneously. The third. If you have had more than one course of antibiotics in the last 3 years, or if you take a proton pump inhibitor regularly, bring this specific question to your GP. Given what we know about antibiotic and PPI effects on the gut bacteria most associated with depression and neuroplasticity, specifically the lactobacillus and bifidobacterium populations, would a structured gut restoration protocol alongside my current antidepressant be appropriate and supported? Do not stop a PPI without medical supervision. Do not change your antidepressant without medical supervision. But this question gives your GP a clinical framework within which to respond, and a GP who has engaged with the inflammatory depression literature will know exactly what you mean. Let me bring you back to where this began. The absence, the grandchild who arrives, the garden that no longer calls, the flatness that is not sadness and does not respond fully to reassurance or to the medications prescribed for the sadness it was mistaken for. The garden has not decided not to grow. The soil conditions have been disrupted. The nutrients have been diverted. The fertilizer has been depleted. The water supply has been carrying a contamination signal that the brain has been responding to with the only appropriate response available: conservation, withdrawal, shutdown. Restore the soil, clear the contamination, replenish the fertilizer. The garden does not need to be convinced to grow. It does not need to be managed through the growing season. It needs the conditions in which growth is the natural outcome. That is what healing the gut offers. Not a treatment for the garden, a restoration of the ground it stands on. Over the next 7 days, note 2 things each morning: your energy level when you wake, on a simple scale of 1 to 10, not your mood, specifically your energy, and whether you went outdoors for any amount of time that day. 2 numbers per day, nothing more complex, because next week I am going to show you the specific foods that have the strongest documented BDNF stimulating effect in older adults, and the one compound, now emerging in the research, that when combined with gut restoration appears to accelerate the rate at which BDNF recovery occurs. Your morning energy scores from this week will tell me which phase of the recovery process is most active for you, and which intervention will produce the earliest measurable change. Come back with those 7 days of observations. One important note before you go: everything in this video is for educational purposes only and is not a substitute for the guidance of your personal physician, psychiatrist, or mental health professional. Please do not stop or reduce any antidepressant or psychiatric medication without close medical supervision. These medications require carefully managed transitions, and abrupt discontinuation carries real risks. Please do not stop a PPI without your doctor's involvement. If you are in crisis or experiencing thoughts of self-harm, please contact a crisis service or your GP immediately. The content of this video is not crisis support. The goal of this video is to give you a more complete biological picture of where depression may be originating after 60E and better questions to bring to the people responsible for your care. Those questions, asked well, can change the direction of treatment. That conversation is where the real shift begins.